Hello, and thank you for having me here today as part of the University of Iowa GWAP Geriatric Lecture Series. My name is Paul Mulhausen. I am a geriatrician with probably about 25 years of experience in the clinic and some time as a clinician educator. And I have been invited here today to speak with you about aging with intellectual disabilities. And you can see that I have given this a subtitle of Double Jeopardy. I do want to disclose that I have no particular financial relationships that impact the presentation topic, and that I don't believe I'll be discussing any off-label treatments or medications. I want to start this presentation by reflecting on the Surgeon General's call to action from 2005, in which the Surgeon General of the United States essentially established 4 large national goals around improving the health of people with disabilities, including intellectual disabilities. And in part, my intent with this presentation is to help us, and those of you who are in the audience watching this presentation, achieve these 4 particular goals. The Surgeon General at that time called on us to understand that persons with disabilities can lead long, healthy, and productive lives. Essentially the point of why we've come together to discuss this topic. It's important that we who are healthcare providers have the knowledge and tools to screen, diagnose, and treat the whole person, a lifespan approach to caring for people with intellectual disabilities, which is another objective of the particular presentation you're watching today. We wanted the Surgeon General called on people with disabilities to promote their own good health by developing and maintaining healthy lifestyles. This presents its own unique set of challenges and opportunities, and we are going to touch on some of those that apply particularly to people with intellectual disabilities. And then it's very important for us as a people to ensure that people with disability, including intellectual disabilities, have access to health care and support services. We're going to illustrate some of the disparity data that highlights the opportunities, and we'll also talk to some extent about support services and how we, who are healthcare professionals, can be more effective or potentially more effective at offering caregivers and people with intellectual disability the support they need to maintain their independence. I want to share with you my own personal story, because one of the questions you might have is, why should I listen to Dr. Mulhausen talk about this? I am a geriatrician. Most of my formal training has been around the topics that relate to health and aging, and disability and aging-related health conditions and problems that impact the elderly. And I have not had formal training in pediatrics or developmental disabilities or intellectual disability. And my interest in this topic comes out of a couple of observations and experiences. So one is my own. And these pictures are pictures of my son, Ryan. My son, Ryan, has Fragile X syndrome, which is a common cause of intellectual disability in America. And over the course of many years, Ryan has gone from being a little baby to being a grown man who now lives on his home in a supportive on his own in a supportive environment at the age of 36. Much of our life experience as caregivers for Ryan have been rooted in just trying to understand and help him through the challenges he experiences because of his Fragile X. And now we're sort of faced with a new set of future problems related to a mature young man who will likely become a mature old man. And how do we plan for that, and how do we help the people who care for Ryan help him be as healthy as he can be as he gets older? Second experience I have is just as a geriatrician, watching people around me and noticing the population of my patients who have had intellectual disability throughout the course of their lives and now have come under my care as a physician working with people who are older adults. So that's my own personal interest. That's what drives my curiosity around this topic and makes it of special interest to me. And hopefully I've done enough of the homework and work-related experience to be able to offer some value in this particular presentation to you. Here are the learning objectives. They seem ambitious. There are 1, 2, 3, 4, 5. But here are the things I'd really like for us to get out of the presentation today. So I want you to be able to describe the changing longevity of people with intellectual disability. This is a fairly dramatic change happening in literally since I graduated from medical school, so in the last generation. So it really does call for a new way to think and care about people who have intellectual disability that really calls for the need for a lifespan approach. The second goal we have is for you to be able to assess the health needs that are frequently unmet in our patients with intellectual disability who are aging. So really it's to try to give us or share the tools that we need to try to meet the unmet need that has been recognized by researchers who've gone before us. I want you to be able to develop an effective care plan for aging people with intellectual disability, basically that capitalizes on the full range of prevention, supportive care, and treatment options that are available. And you'll find that most of the energy I'll spend we'll spend most of our energy talking about healthy behaviors and ways to support that, or at least think about it. And then also some of the age-related problems that are frequently unmet in people with intellectual disability because we're focused on their diagnosis that's causing the intellectual disability as opposed to thinking about them in the context of a lifespan. I want you to be able to educate and support individuals with intellectual disability and their caregivers in physical activity and healthy nutrition to promote wellness, taking advantage of that preventive domain. And I want you to be able to develop and implement strategies for reducing care burdens for families of individuals with intellectual disability, and try to help reduce high rates of turnover in non-family caregivers. So the first objective is to help us understand that we need to think beyond the particular diagnosis, the particular syndrome, the particular condition that is at the root of the intellectual disability, because our patients with intellectual disability are living longer. Now the graph you see here is really is uniquely describing the new longevity in people with Down syndrome. But you can see that in 1929, the average lifespan of a person with Down syndrome was 9 years old. And today, it's very common for people with Down syndrome to live to be 50 years old. and even older. And many people with intellectual disability now live longer than the average life expectancy in the United States. And just for perspective, so I graduated from medical school in 1987. And since 1983, you can see where the graph really takes an inflection there. So since 1983 alone, the average lifespan of a person with Down syndrome has doubled. This is truly a new phenomenon for us. And the challenge we face is the approach that we take for people who have these medical problems that result in lifetime intellectual disability. This particular graph illustrates that the survival does depend on the severity of intellectual disability. So those who are most severely impaired have shorter life expectancies than those who are the least impaired, which is not unexpected. So there is some variability yet among people with different levels of intellectual disability, and I thought it would be helpful to have some insight into that variability as well. So the bottom line on this is that increasing numbers of people with disabilities that once resulted in premature death now live for or exceed the lifespan for the average American, 76 years. And what it calls for those of us who are healthcare providers really to adopt a lifespan approach, right? That recognizes the progression or consequences of specific diseases, therapeutic interventions, side effects, and the impact of aging on our patients and people we know with intellectual disability. Which brings us, I believe, to objective number 2. Yes, objective number 2. So one of the things that I wanted to highlight here again is people with intellectual disability are getting older. And in part because of that aging experience, they have a greater burden of unmet need. 10 of which I've listed here in this particular slide. And what we know from the research on those of us who take care of people or who healthcare providers who work closely with people with intellectual disabilities is that the healthcare providers involved often focus on the disabling condition rather than on the other healthcare issues that might be of concern to the individual. So my son has Fragile X syndrome. Focusing on the Fragile X is where really all of the energy has gone, certainly through most of his life. And one of the big challenges we faced as he matured into adulthood was the challenge of finding information around supportive services, housing, and helping him through some of the behavioral challenges that he was experiencing. And I think our personal experience with Ryan highlights the challenges that many people with intellectual disabilities face, which is they're working with experts in their particular condition, and there's so much energy being focused on that particular condition that we often are not given necessary attention to some of the secondary issues that become highly relevant over the course of a lifespan, especially if one lives into old age. So here are a couple that I think are really, I'm just going to pick on out of this 10. So complex health conditions, so comorbidities, very complex problems, familiar to those of you in geriatric care. Missed cancer screenings. This is, I think, a huge potential opportunity, but an approach, a problem that requires approaches that may have to be accommodated or distinctly different from the approach we take with our patients who don't have intellectual disability. Undetected poor vision is one that, as I have done my own homework in this area, I've reflected on the care of my own son and whether or not we really know whether Ryan has good vision or not. And there's a clearly recognized unmet need across people with intellectual disabilities that their vision is not being screened as effectively as possible, and they're not receiving the kind of treatments like eyeglasses that one might need. I spend a lot of time with dentists who have some deep insights into the unmet oral health needs, and I routinely listen to family members who struggle with taking care of the oral health needs of their children with intellectual disability who are now adults. So these 10 unmet needs are areas where in the course of our work with people with intellectual disabilities who are getting older, we can focus some of our processes, our workflow, and our energy to help them close those gaps. Just to highlight the opportunity here, I wanted to share with you this particular graph, which is essentially longevity stratified by race. And if I remember this graph correctly, it's for people with Down syndrome. Yep, there it is in the top there. And what you can see here is that for Caucasians who have Down syndrome, their longevity, their age at death, is substantially better than the other races noted here, which gives some insight into the huge opportunities to improve access across communities, across neighborhoods, across ethnicities, across race, to close these gaps, reduce unmet need, improve longevity for all of us who live in America. So here are a few things that I want to just highlight that need to be addressed to really meet the needs if you approach the person with intellectual disability with a lifespan framework, thinking beyond the health condition that causes the intellectual disability, and once again doing what many of you do well, which is to combine disease and condition management with measures to help people grow old and be well in their old age. So really we need to have regular assessments to optimize treatment and prevention. Now this is not easy, and I'm not trying to frame it as easy. I'm just saying these are the things that we would need to be doing. So managing the associated conditions. So we either have to have the insights into the particular conditions that people with intellectual disability often experience disproportionately, and insights into the other secondary conditions, which are, I think, common to many of our older patients. So we have to be able to review and manage medications. Again, standard procedure in geriatric care, making sure that we're keeping track of medications, not only to help them manage the medication treatment program, but to manage the side effects. Diagnosis and intervention for behavioral health and mental health disorders, that becomes very important. Adherence to general population guidelines for clinical prevention, and then monitoring of the conditions that you see below, or biometrics might be a better way to say that, of hearing, vision, weight, height, skin. Now, one of the reasons I put this slide in here is that I'm perceiving that most of our audience are people who are especially interested in geriatric care and think hard about geriatric care. And if you're looking at this slide and going, hey, this is geriatrics, that is kind of my point here. The models of care that we have found to be uniquely helpful to our geriatric patients, our patients who are growing older, apply, in my view, nicely to a lifespan approach to caring for people with intellectual disabilities, which really is the essence of what I'm trying to get across today. Regular dental care, we're going to talk more about that, but that would be a very important component of the care. There's going to be needed specialty care. I am quite confident that my son, Ryan, we could not have had as a rewarding life experience with Ryan as we did without the input of specialists into Fragile X and some of his mental health related mental health conditions. So being able to integrate the specialty care that's required for most of us in the healthcare profession to really help our patients with intellectual disability optimally is going to be very important. And then providing healthcare coordination. And we're going to talk a little bit more about some of the unique opportunities there. Empower caregivers, listen to family members who, to meet the healthcare needs of intellectual disability. My friends who also have children with Fragile X, find that the healthcare professionals who really listen to the caregivers are those that are most effective in the course of helping them through both the day-to-day struggles of caring for people with intellectual disability, as well as the more acute problems that can arise. And then on top of all this, promoting healthy behaviors. And we'll talk a little bit later on in the presentation why that ends up being especially important if we're caring for people with intellectual disabilities. Like in geriatric care, effective care requires individualized approaches. So I may be promoting a standardized set of areas to focus energy, but in reality, ultimately the treatment plans and support that's given has to be uniquely individualized. So what we know is that although there's a lot of interest in how the aging experience is different for people with intellectual disabilities, there is a lot of variability. And there's still some debate about whether people with intellectual disabilities have a uniquely aging experience. I don't want to get into the middle of that debate. The point I want to make here is that people with intellectual disabilities now are going to get older. Many of them are going to get older. And to help them be as healthy and have as good a life as they can have, it's going to be important for us to think about how to help them be healthy as they get older. And then what is generally accepted about what's different for people with intellectual disabilities as they get older is a unique crisis of living arrangements that happens to them uniquely when their caregivers get older. And we'll talk about that. So there is consensus about the planning that's needed. And you'll find as we get towards the end of the presentation, I spend a lot of time talking about that as we go. All right, so I've given a subtitle to this presentation called The Double Jeopardy. And really the double jeopardy is trying to highlight that in this particular slide. And I know it's a redundant theme, but redundant themes can be good if you're trying to get a point across. And the point I'm trying to get across is that the double jeopardy is one, the underlying medical problems that happen literally as a result of the intellectual disability and the condition that's causing that. And then two, the double side is all of the usual aging related problems that take place for all of us as we get older. And so it's the double jeopardy of, boy, I have I know somebody with Down syndrome. We've got to help them with the problems that emanate from their Down syndrome. And now they're a person with Down syndrome who's 55 years old and getting older. How do we help them avoid some of those other age-related problems that all of us, or many of us, experience? And if they do develop the problems, how do we help them with those problems most effectively? Here are the common underlying problems that cause people to have intellectual disability. I don't want to spend too much time on this slide, but it does highlight the common medical conditions that result in intellectual disability, and knowing more about those particular syndromes can be helpful to people. Fragile X syndrome is up there. That's what my son Ryan has, and many of us care for people with Down syndrome, and then people who suffer from fetal alcohol syndrome. So this is just a listing to remind us that we need to either work with, collaborate and integrate our work with specialists in these domains to make sure the issues emanating from their primary condition are addressed, or develop the knowledge base to help them more effectively ourselves. So here are some areas that are proposed areas of focus for primary care. And really I'm framing this in the context of primary care. So these would be the areas of workflow and care process and knowledge development that can be uniquely valuable or especially valuable for those of us who care for people with intellectual disabilities. Preventive care and how to apply it effectively for our patients with intellectual disability. Cancer screening is a unique set of challenges, and we'll talk more about that. We've already mentioned vision and hearing problems and establishing processes of care that make sure that gets screened. People with intellectual disabilities are at a higher risk for gastroesophageal reflux and constipation, so having some insight and expertise into those problems. Cardiovascular disease, there's still some debate about the burden of cardiovascular disease, whether it's excessive in people with intellectual disabilities or the same. Regardless, getting older is a risk factor for cardiovascular disease, and we have to make sure that it's not something we neglect. Dental problems, people with intellectual disabilities see their healthcare provider a lot more frequently than they're seeing their dentist. They may not even be able to find a dentist who would accept their payment methods. So finding helping them with some of the dental problems, help them identify, helping them screen, referring them on to dentists that can help them and have payment mechanisms that they can take advantage of is something that we need to be thinking hard about as we care for people with intellectual disabilities as they get older. Epilepsy. I have a lot of patients with seizure disorders. I continue to maintain I'm not an expert on seizure disorders, but there are some unique side effects that I think often fall through the cracks. And we'll talk a little bit about how keeping those side effects in the back of your mind and working closely with a colleague who is an expert on managing seizure disorders can be helpful. There's a lot of antipsychotics used for behavior problems with people with intellectual disabilities. And in the same vein that we see a lot of antipsychotics being used for people with dementia, helping them manage those problems and manage those medications with the least the burden of side effects becomes very important. Sexual health is important for caring for people with intellectual disabilities. I'm not going to spend a whole lot of time talking about that, and I appear to be redundant in highlighting cancer screening. But the slide is really to help you think through, okay, how do I establish my flow sheets and my workflow for people with intellectual disabilities? Now this ends up being very important in terms of how you design how you work in the clinic, or how you're interacting, because it's very clear that the need to alter workflow proves to be a barrier. So let me just create a classic example. So when you're working with someone with an intellectual disability, you're going to have somebody there who is a decision maker, which means that the encounter has to be designed in a way that accommodates both the person with the intellectual disability, a caregiver, and or a caregiver who has decision-making authority, right? So you've got to be able to design the workflow around accommodating the multiple people in the room. You have to design the workflow around the time requirements for this, and oftentimes that proves to be a barrier to effective access to care. And my plea here, or our charge, is to overcome those barriers and make it work. Accommodating approaches to intrusive interventions. And I'm going to give you an example from Ryan's life. So Ryan, for many years, anytime he had to get any kind of dental intervention, had to be sedated. And you can imagine how invasive medical procedures, whether done in the context of monitoring, diagnosis, or even prevention, can be both painful, frightening, and may require time and accommodation that's distinct from the time and accommodation that we provide for people who don't have intellectual disabilities. And so I'm just going to invoke here the bimanual pelvic examination and how difficult that is for women even when they don't have cognitive impairment. And if you are a woman with a cognitive impairment, and it's both painful, frightening, and confusing, can be especially difficult for them. Integrating and coordinating with community services and specialty care. So it's unlikely that those of us who are working with people who have intellectual disabilities will have all of the knowledge that we need. So now we have to make sure that our workflow and our processes and our communication strategies truly integrate the care and coordinate with both the community services of people who are working directly with the people we work with and care for, and with the sort of the specialists. And then optimizing the comprehensiveness of primary care. And what I mean by that is that there's a lot that can be done in primary care, but it does require us to have and develop and own the knowledge base we need to do that. How to change the workflow, how to accommodate people for some of the more uncomfortable treatments and interventions that are appropriate for promoting health across the lifespan. Now, I wanted to spend a little time talking about integration and coordination, because I think these really honestly present unique ways to think about person-centeredness and new opportunities for many of us to do a more effective, take a more effective approach for our patients with intellectual disability. Many of my friends who have children, adult children with intellectual disability, don't live anywhere close to somebody who has disease-specific knowledge. So let me again pick on Fragile X syndrome, since that's a personal experience of my own. So I live in a big community with a big hospital who has a Fragile X expert, okay? Pretty easy for me to get to the Fragile X expert with my son Ryan. But most of the people I know don't live in a community with anybody who has any expertise on Fragile X, and it requires a 4-hour ordeal to engage in the encounter with the expert on Fragile X that may last, 20 minutes or so? So one of the unique opportunities for all of us to think about is the role of telemedicine and ways that we could potentially optimize a comprehensive primary care experience through telemedicine with some of the specialists who know more about the disease-specific or condition-specific issues that need to be addressed, right? So that is an opportunity for us to think about in the context of newly evolving technologies. And then something a little more concrete at home to think about. So I want to go back to Ryan's experience where if he's going to have his teeth cleaned, he'd have to be undergo general anesthesia. So many of my friends who have adult children with intellectual disability, they can't get their hair cut because of the behaviors that arise out of the haircut. They can't do basic nail hygiene, again, because it's scary and uncomfortable. And I have a good friend who highlights the experience that her family had when, in fact, during a particular procedure, when their son had to be under general anesthesia, they were able to complete his haircut, get his blood drawn, do some basic kind of screening, get his toenails clipped. And this ability to coordinate and deliver services that are uniquely special accommodating that we don't think about at all or almost take for granted in the context of caring for people without intellectual disabilities, this really presents a unique opportunity for us to better coordinate and deliver the services. So I want you to, to me, that story highlights some unique opportunities, and I want to make sure that that's on the radar screen as we think about, again, lifespan care. All right, at this point in the presentation, what I want to do is just sort of go through a series of age-specific issues that are not unique at all to people with intellectual disability, but are uniquely unmet. Okay, so do you see the difference there? So again, if your experience with people with Down syndrome is that they don't live to be old, right? Like would have been the experience up to when I graduated from medical school. Just think about that. So, but now they live to be old. And so now if I'm used to caring for a person who died at the age of 9, and I'm now faced with a group of people who are going to live into their old age, these issues become relevant, but we haven't sort of made the culture shift to apply this knowledge across the board, which is why I'm here talking to you about it. So cardiovascular disease, the bottom line on this one is as people with intellectual disabilities get older, their risk factors for cardiovascular disease are greater than the general population, and it becomes relevant and important to help them with screening and management of risk factors for cardiovascular disease, including lipid disorders, diabetes management, and high blood pressure management. Gastrointestinal problems, as we talked about early, are very common. About half of people with intellectual disabilities suffer from some kind of gastroesophageal reflux disease. This can be especially useful, Pearl, if you're working with persons who are severely impacted by intellectual disability because they may not be able to tell you, I have heartburn, right? So it can present in unique and different ways in people who have intellectual disability. And so just knowing that it's very highly prevalent, half of them have gastroesophageal reflux disease, I think can help you to help your patients feel more comfortable. They also have a heavy burden of Helicobacter pylori infection. Now, to my knowledge, there is no need to necessarily be screening people for H. pylori simply because of gastroesophageal reflux disease. But again, given this heavy burden of H. pylori, if you find your patients with intellectual disability with peptic ulcer disease, remember, check for the H. pylori and treat it. And if you happen to find somebody who is infected with H. pylori, pylori. As I understand it, it is the standard to treat the H. pylori infection. Constipation is a common problem. Again, those of you caring for the elderly, this is not unique, but it is common. So you can see constipation affects up to 70% of people with intellectual disabilities. It's not going to be a simple fix, likely. It's very likely will require ongoing treatment. The point here is that it's a common condition, frequently missed in the early stages, and you want to recognize that there's a lot of opportunity to help your patients with intellectual disability be more comfortable by treating their constipation, recognizing and treating their constipation. The pearl here in the osteoporosis domain is that fragility fractures are more frequent in adults with developmental disabilities. There are a number of condition-related risk factors. So low vitamin D, especially those who live in institutions. There are frequently thyroid hormone supplementation, especially in people who have Down syndrome. Antipsychotic medications are common, and as you know, they impact bone health and bone density. And anticonvulsants are notorious for their impact on bone health and bone density, increasing the risk for osteoporosis. So recognizing that osteoporosis is a common problem for people with intellectual disability becomes really important, an important pearl. They're taking anticonvulsants, they're taking antipsychotics, they're taking thyroid hormones, and they aren't, they are predictably, I mean, there's unique circumstances, but they are predictably spending less time outside. And here are some suggestions to think through. Ensure that they're getting adequate nutritional intake of calcium and vitamin D. Consider measuring their 25-hydroxyvitamin D, especially in those who are taking seizure medications. Encourage smoking cessation. My son's roommate likes to drink and likes to smoke. So again, don't assume that, oh, they have an intellectual disability, they have no potentially unhealthy habits. So again, encourage smoking cessation, encourage, I can't even read that. Alcohol, we talked about that. Encourage avoiding excessive alcohol intake. And of course, encourage regular weight-bearing exercise, and we'll talk more about that as we go. There's a little bit of controversy in my mind about when to screen for bone density. I spent some time trying to understand, you know, should we be screening them, people with intellectual disability, at an earlier age? One of the things for you to think about is that there are some experts in the relationship between osteoporosis and anti-epileptic drugs who have recommended that there be bone density testing for those who are taking anti-epileptic drugs, but I haven't found an age at which to do this. But in this article referenced at the bottom, promoting a primary care lifespan approach for people with intellectual disabilities, that particular group recommended screening at age 40 for people who are living in institutions, or at age 45 for people with intellectual disabilities living in the community. I do not know how the payer community feels about that. It's difficult for me to say that's the standard of care. This is what I could find in terms of offering guidance for screening for bone density outside of the usual recommendations. Treatment should not really be necessarily any different. There's no reason to think that treatment should be any different for people with intellectual disabilities than those without. But remember the issues around side effects and accommodation. So with bisphosphonates, the issues around acid reflux disease and the need to accommodate, taking the medication become very important decisions. So really the decision making around osteoporosis treatment is going to reflect the potential side effects and the administration requirements probably more than usual than we do for people without intellectual disabilities. I'm going to spend a little time talking about vision and hearing impairment because I think this is honestly something that is very clearly an unmet need. So vision and hearing problems are common. We know that eyeglasses are underused, and when they are prescribed, they're not necessarily worn as effectively as they could. When people have tested vision and asked caregivers if they recognize the vision impairment, there's a disconnect there. So just asking caregivers like me, hey, does Ryan seem to see okay, is not as effective a screening strategy as you might think on the surface. So it's very important to screen vision and hearing at regular intervals. And again, it's difficult to know what's a regular interval. Some have recommended annually. So that might be something to think about. A once a year visit to a clinic that can accommodate the specialized approaches that one would need for screening people with intellectual disability for hearing and vision problems, and making sure they have the devices that can help them with vision and hearing. Oral health care. So this is a huge problem for people with intellectual disabilities. So it's not necessarily a problem that we're going to solve in the doctor's office. It really does require an integrated approach with an oral health care professional like a dentist or dental hygienist. But this really is something that I hear both from the advocacy community as well as the provider community. So screening for oral health problems, helping people with intellectual disabilities get dental treatment, helping people with intellectual disabilities provide their own oral hygiene, helping caregivers of people with an intellectual disability provide or support effective oral hygiene. This really becomes very important. And then because many people with intellectual disability are poor and using Medicaid for dental services, finding a dental professional that will accept Medicaid and accommodate their needs becomes really important. And maybe even worth some work ahead of time to sort of say, okay, let's work together. We'll figure out how to integrate the care as a team. This is a geriatric talk. It's the geriatric lecture series. One of the core knowledge bases in geriatric care is dementia care. And when I talked to the administrator of this particular program, it was one of the things she asked me to sort of reflect on is the issue of dementia. As many of you know, some of you probably know more about dementia than I do. People with Down syndrome, with three of the chromosome 21 genes, they're predisposed to developing Alzheimer's disease. And you can see the statistic here that, 40% of people with Down syndrome will have dementia by the age of 60. So a substantial burden of dementia and Alzheimer's disease in people with Down syndrome. As far as we know, with other conditions of intellectual disability, the risk and rate of dementia seems to be similar to the general population. So they aren't necessarily at increased risk as people with Down syndrome are, but they are at risk for developing dementia. And as you remember, getting old is the biggest risk factor for development of dementia. One of the unique features of the presentation of dementia in people with intellectual disability is that the initial presentation is often a behavioral or psychological symptom of the dementia, which isn't surprising in light of the baseline cognitive deficit, all right? And because of the baseline cognitive deficit, it can be very challenging to diagnose and really depends very heavily on caregiver informant history to make the diagnosis. So one of the pearls here, especially in people with Down syndrome, is if your patient with intellectual disability experiences some kind of behavioral, psychological symptoms that are new to their experience, thinking about, well, is this a manifestation of dementia as opposed to the cognitive impairment from the Down syndrome becomes an important thought process. And this is what makes it especially difficult. So the assessment of dementia in people with intellectual disabilities is complicated, and it's primarily because of the baseline intellectual disability. Their life has been impacted by cognitive impairment, and recognizing changes from the baseline premorbid cognitive impairment is the great challenge. And so because in the general population, we diagnose dementia based on the assumption of a formally intact cognition, right? So you score a certain point on a standard screening test, you are at a high risk of dementia. It assumes a baseline premorbid normal cognitive function, which cannot be assumed in people with intellectual disability. Now, there are a number of tools available to try to help clinicians, but primarily researchers, with this challenge. So the clinical assessment of dementia in people with intellectual disabilities has resulted in a variety of tools that I've listed here. Some of them are informant-based questionnaires, and some of them are self-tests of cognitive function. They are available, and really that was my point. And as we look, I'm going to pull this particular reference, not that one, this one, over to make sure you all can see it. Because that's where you might be able to find some of the tools if you're interested in taking a deeper dive. There are a wide variety of these assessments, similar to there are a number of these assessments for the general population. And I guess at this particular time in our knowledge, there is no standard process or tool to be able to promote or advocate to help you with this challenge. The good news is that clinicians who are very experienced working with people with intellectual disabilities are quite good at distinguishing the ones who have developed dementia versus those who have not. I think the challenge for people like me would be I have a few patients with intellectual disability that hardly makes me an expert. How to help me distinguish between a person who's still functioning at a baseline premorbid level of cognitive function, but experiencing some other mental health problem, like maybe new onset depression, and distinguishing that from a new onset dementia can be very difficult. But those of you who are spending a lot of time working with people with intellectual disabilities actually become quite skilled at recognizing when they experience this change in cognition. All right, so that's really talking about some of the diseases and the age-related conditions, and now I want to talk about wellness, good health, and healthy behaviors. People with intellectual disability are at a higher risk for diabetes. That's really rooted in their greater prevalence of overweight and obesity, as far as I understand it. And if you think about overweight and obesity as a risk factor for a variety of health conditions as we get older, this topic is going to become relevant. And I also see it again in the course of my own son's experience as a young man, actually in his mid-30s. So this particular graph just highlights the point. People with intellectual disabilities are at a higher, have a higher prevalence of overweight and obesity. This varies across setting. It's interesting. I find this particular graph interesting. And you can see that the overweight and obesity rate is lowest in people who are living in institutional settings and highest in people who are living at home. I don't know if that's been controlled for by severity as I reflect on that graph here. But it's an interesting phenomenon, and I think I have a slide that really talks a little bit more about this. Yes, here, right here. So we know that people with intellectual disabilities are at risk for obesity. We know that in general they are less likely to engage in physical activity. And we know that for all of us, increasing levels of physical activity is probably the most effective single intervention to improve the health status of anybody we're working with, but especially important for the population of adults with intellectual disability. All right, less than a third of people with intellectual disability engage in the recommended levels of activity. And there are tons of barriers here. And many of them are cultural, some of them are their intellectual disability, and some are almost an empowerment issue that, as a loving caregiver, presents a conundrum. So the cognitive barriers are, why should I exercise? If you don't have a lot of insight into the fact that you might be 75 and sick if you don't exercise, you can't predict the benefit, the health benefit of the exercise. Hard to get motivated around it, or a sense, geez, I just can't do that. Loss of low self-efficacy, and then of course caregivers who just say, well, what do we expect? What do you think he's going to do? What do you expect of my son Ryan, who has an intellectual disability? And the other is that I find it's sometimes difficult to help the social structure in which he works create the discipline structure around helping Ryan exercise and eat healthy. And the cultural phenomenon is that we want to empower Ryan. He's an adult. We want to give him choices, empower him as a human being worthy. This is going to sound awful, but I hope you understand my sincerity. A human being that should be treated with dignity. How do you give him choices? And of course, Ryan, in my view, doesn't really understand the choices, and oftentimes we have to ask him to do something he wouldn't naturally do on his own, to provide some structure to help him lead a healthier lifestyle. And these are interesting and unique and challenging opportunities for us to try to address. There's the whole issue of accessibility. So are you living in a neighborhood where it's safe to go for a walk? Can you get access to a treadmill machine that lets you walk if the weather is bad? And then, of course, I often find that the people who care for my son Ryan in his group home really aren't especially motivated as routinely as it would be helpful to provide sort of a discipline structure around daily physical activity. And as we'll talk about here in the next couple of slides, more wholesome nutrition. But there are some things that have been done that work. So I'm explaining all the barriers, but there have been programs that make this work. And so encouraging physical activity and exercise wherever and whenever possible, sort of helping influence the cultural environment. There are targeted exercise programs to help people with intellectual disabilities. They have demonstrated that fitness improves, function improves, confidence, that low, what's the word I used in the previous slide? Low self-efficacy. Their self-efficacy improves. They're more confident in their ability to do the exercises, and they actually find better quality of life, life satisfaction scores in the people that participate in these programs. So these opportunities exist. There are opportunities to scale them up, and there are opportunities to work with health clubs. I work very close to a YMCA. I called up the YMCA. I said to them, what do you offer for people with intellectual disabilities? And there are huge opportunities to collaborate with people who have health exercise programs and how to integrate our work with them. Nutrition. So this is another one. As a parent, I go, oh my goodness, look at the food here. So people with intellectual disability are clearly, again, at a higher risk for overweight and obesity, and studies pretty routinely show that their dietary intake is poor and generally worse than that for the general population. So here's just one survey to illustrate the point. No one in that survey, this was a survey of people with intellectual disabilities, had an intake of 5 or more servings of fruits and vegetables per day. Their intake of fat, saturated fat, and cholesterol, interestingly, was within guidelines, but they had excessive amounts of sodium, and they did not have high fiber foods. There is a lot of opportunity for improvement in nutrition. And again, I want to highlight some resources that are available out there that can help you. Now, the first resource that's, I think as you look at the slides on your left, Health Matters, it's a book. You can buy it on Amazon, and it's a whole program of exercise and nutrition, health education curriculum for people with intellectual disabilities. The middle slide is from the University of South Carolina, and the link here down at the bottom, this ablesouthcarolina.org health initiatives is where you can go and get more information about that. And then the resource on the right there is from Oregon Health Sciences University, which is the Healthy Lifestyles Program. Again, resources to help people caring for persons with intellectual disability with both the physical activity needs as well as improved nutritional needs that are essential for really lifespan care. And then the last topic I really wanted to spend some time on is around late life planning. And this is rooted in my own experience where the transition from adolescence to adulthood was so challenging. And I imagine that same transition from adulthood to old age. And here are the stats that highlight this need. So 1/3 of adults with intellectual disability live with a family member who's over the age of 60. And those people who are living with a family member are more likely to be socially and economically disadvantaged. So here's this unit of your patient with intellectual disability and their family caregiver who's getting old. Okay? And so given that there's a sizable number of people in this kind of circumstance, it means that in the next decade, as their caregivers age and or die, we'll have to be moving into a new social environment or have a new set of social support needs. And the main concern of family members caring for a loved one who's in late life or late maturity is what's going to happen to them when they die. And you can see this last statistic is 2/3 of them haven't even thought through, what do I do if mom, it's usually mom or a sister, gets sick and can't take care of them. So it really highlights an issue around late life planning. And at one level, as a physician, I think about that and I go, God, how could that be? How could you not be figuring that out ahead of time? And I think I got some insight into that, again, both from my own experience with Ryan, as well as some events that have happened over the course of the last 10 years or so here in Iowa. And the fear is really one of a fear that the person you love will be neglected or taken advantage of. There's probably a better word for that, but taken advantage of. And this is a story from Iowa. This is a story that was written up in the New York Times and labeled "The Boys in the Bunkhouse." And there's a series of resources on the New York Times website about this. And I just want you to see this one clip about the revelation when the care of these men, aging men with intellectual disability, came to light. And I want you to watch this particular video. It only takes about a minute or so.
Other than the snow, this is exactly what it was in February of 2009. Same color, same windows. This is a bit misleading because we really couldn't come out this door. It was blocked.
Denise Gonzalez was a supervisor for the Iowa Department of Human Services, but her 20-year career in social work had not prepared her for what she saw inside.
The rodent feces was everywhere, in the kitchen area, in the bedrooms, on the stairs, and the roaches. I mean, you could see them, they would fall off the ceiling. A lot of them. You know, they had like an open bathroom area, and you could see the mold on the walls. Their blankets had, you know, mold in them that you couldn't get out. And the smell, you can't, I'll never forget that smell. You could see their filthy, stained clothing and this. They were arthritic and their hands were like this. Their fingernails were long and embedded with, now I know, turkey blood. It's hard to talk about. There are 21 men here that need to be rescued.
To me, that story highlights the fear. Who wants to plan for that, right? My loved one is not being abused, not being taken advantage of, and is not being neglected under my care. And I will do my darndest to live long enough to take care of them. So ultimately, that fear drives, in my opinion, a lack of planning. And that, for many older adults with intellectual disability, creates a crisis point in their life, usually sometime in their 40s or 50s after the death or illness of their family caregiver. And if you think about that, it creates this huge source of discontinuity, a lot of potential for loss of support. And as you can imagine, if you're the parent or caregiver for a mature person with intellectual disability, creates a lot of stress and anxiety, actually both for the caregiver and for the person with intellectual disability. So one that I really was initially, I thought, really, I hadn't thought about that before, was this whole notion that, okay, if I get old and I have to move into a new living environment, what happens to where I was before? Dayhab, my friends there, my experience there, sort of this fear of exclusion, which I found to be a helpful insight in terms of my thinking about this. So helping caregivers and your aging patients with intellectual disability prepare for this circumstance is extremely helpful, right? They need information about housing options. They need to be able to see the resources out there. They need to see the support system in action, that they can understand how their loved one will be cared for. We now have, in my own life, we have now about 15 years of experience with Ryan living in a group home setting, and I'm pretty confident as a parent that we're much more reassured that in 20 years when I'm dead and Ryan's in his mid-50s, that he will be well cared for and protected. So they need practical support, they need information and awareness of the options, they need some proactive information and support for planning, even just to create an emergency backup plan, and they need supportive preparation and practice for the separation. So giving, helping your patient, go through the experience where they get away from a weekend from their caregiver or loved one, just to sort of start to get everybody ready for, what will happen potentially in the future. And of course, that's not going to happen in our offices, and it's not going to happen over the course of our home visits. So knowing where you can turn and who you can refer your patients to becomes exceedingly helpful. We in geriatrics often work in interprofessional teams where psychosocial assessments are taking place and addressed. In my own personal experience, I work with social workers who do this seamlessly and with excellence. And so it really wasn't so much of a challenge for me to think through how to help my patients with this domain. But I also spent some time practicing in a very rural setting in a county in Iowa that doesn't even have its own county human services department. And so what do you do if you're out there and you're trying to embrace these same concepts? And there are two, these are very Iowa specific, so those of you who aren't in Iowa watching, these are very Iowa specific. Lifelong Links is the name for the Iowa Aging and Disabilities Resource Centers. There are aging and disability resource centers across the country. They probably have different names. But here in Iowa, the Lifelong Links resource is available. And I call them up and say, how can you help me? Sometimes they'll refer you to the county Department of Human Services. Sometimes they can directly help you. But Lifelong Links is a very potentially useful resource. And then referral to county social services. So again, the county in which I worked, we used the Mahaska County Department of Human Services, and they can help as well in terms of thinking through and planning what resources are available in the community where you live. So, thank you for listening to me. This is a topic of passion. I don't routinely get the opportunity to speak about it, so if it felt unprepared and unpracticed, I apologize. It was unpracticed, but very heavily prepared. But I appreciate the opportunity to be able to discuss this topic with you. Just to try to summarize my points, people with intellectual disability are living much longer than they used to. And because of this newfound longevity that has really only been present in the last generation, we need to rethink our approaches to their care and apply a lifespan approach to care that includes consideration of how to help them mitigate the aging-specific problems that they are likely to encounter, as well as helping them manage the disease-specific issues that we have always done our best to try to treat. And then remember that the social support needs of people with intellectual disabilities change over time. They may have successfully negotiated that transition from adolescence to adulthood, and then now there's this second large transition that we may have to help them through, which is the aging experience, as well as the changing social support needs, and helping them plan for the anticipated changes that happen when they are growing old with caregivers who are even older. So thanks for your attention. Hope it proves to be helpful to you, and be sure to stay tuned to the next lecture in the geriatric lecture series.